This is a video about starting out in nursing in ICU. Now, in my previous video, I did say I wasn't going to comment on that, like P's or ICU, ER, or anything like that. But this one specifically ICU, and the reason for it was I actually was planning on doing the video anyway. But also, there was a commenter on my last video about, new RN suggestions, specialties. And I forgot who the commenter was, I'm sorry. But they really took me to task about being an old dinosaur of thinking how ICU training is traditionally done, which is you're a med-surg nurse for X amount of time, and then you transfer into ICU, and then trained for that. But a couple things got me to thinking. It wasn't actually, I was going to plan to do this video even before the commenter posted their critique, and they took me to task, and I appreciate it. I actually like that feedback. No problems. I don't take any offense or umbrage to it. I was going to do the video anyway because I think I have, out of all the specialties besides med-surg, I think I have a good feel on that. One, because I know so many ICU nurses. My daughter's an ICU nurse, just graduated earlier this year, so she's exactly that track. And she's pretty typical. I know some of her friends are in the program. I know also nurses that are in her cohort that I worked with that went the traditional path. Okay, the traditional path is, again, being med-surg and then ICU. And the non-traditional path, let's say it that way, is the new grad nurse going into ICU directly. And besides my daughter, my girlfriend is a NICU nurse, and she had spent almost 2 decades, about 16 years or 17 years in NICU, training nurses. She was one of the main preceptors when she was transferred out into her new role as a researcher. And she gave me feedback too. And she's, the real feedback when we're sitting down at dinner, and she's like, "Oh my God, I was precepting today, blah, 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 blah." We talk about that. And my daughter gives me her feedback and bounces stuff off of me about her day and her cases. So I have that perspective, besides also working with a lot of ICU nurses themselves, because, traveler contracts get paid. It doesn't matter what you are. If you can get the traveler contract, you're paid a lot. So even though they might be ICU nurses in their home hospital, they are just quote unquote med-surg nurses on our unit. So and knowing that my daughter was going into ICU directly, over and above my objections, over and above my disrecommendations, I did not recommend her to do that. I started preparing myself and for her and her eventual questions and any kind of hurdles, what she should look out for. So I had been doing this preparation of ICU new grad for my daughter's sake for a while. And there was actually, and then it just reminded me, there was actually another commenter. I don't know if it was John Montana. He had asked a couple questions. I think this was one of his questions too. It's like, what do you, or was it Ecos? One of the commenters was saying, what should new ICU nurses be looking for that's different than a med-surg? So I have a couple questions on this. Hopefully I'll keep this short and sweet. Let me address that one real quick, because that's pretty quick. Is ICU nurses are, what you're looking for, different than in med-surg. Med-surg, we're doing a quick assessment depending on what your specialty is: neuro, pulmonary, ortho, renal, whatever. You're going to be looking at those specific areas primarily in doing a workup. Like for me, I just transferred to pulmonary from neuro, so I'm still looking neuro, but now I'm also assessing breath sounds and breathing patterns and whatever a lot more, and certain lab values. And that's the key thing for ICU versus everything else is lab values. Over and above everything, maybe except for OR nursing, but really it's the anesthesiologist is dealing with that really more than anyone, is the lab values, the vitals. You're giving constant feedback to the resident or attending that's sitting there in ICU. And that's what they're looking at, because they have all the patients. The doctor's got everyone. She has to watch 20 patients. You're only watching 1 or 2. That's her responsibility. So she's, checking numbers constantly, and that's her feedback. Yes, yeah, you can walk over and say, "Hey, doc, I know the numbers look good, but I don't like the way this patient." Then, they escalate that. That's their RRT. Basically, it's a 12-hour RRT anyway, in the ICU. That's what I said to them when I flew down there. I was like, "Damn, this is like a 12-hour RRT." And they're like, "Yep, welcome to the ICU." And I was like, "Fuck that. No, thank you." But that's what ICU nurses have to really know. I mean, you have to know your numbers really hard. That's why I said to my daughter, that's one of my first pieces of advice I gave her. And she's like, "Oh yeah, I see what you mean. You got to know." For me, I'm like, okay, calcium's this, prealbumin is that, big deal. What's her hemoglobin really? What? Okay. For them, they need to know quickly. They need to know constantly, in the sense of every 4-hour draw, 3-hour draws, whatever, that kind of thing. You're drawing your own blood and getting these lab values and doing ABGs, and you got A lines in and so et cetera, drips going. So that's a big differential between med surg or anywhere else to ICU. The information is real time. And that climbs in escalation as you get to PICU and NICU. Okay, NICU, it is literally real time. So you're staring at the patient's right in front of you, and you can't look away. It's like a lifeguard. I said it's like kind of like a lifeguard. The concert could be going on in the back of you. Lifeguard's you got to stare straight ahead. And it reminded me of when I was in a spring break, and it was a Bangles concert of all things. I don't know why it's stuck in my mind, the old group. And the concert was going back, and these couple of lifeguards were staring out into the ocean. Literally, they couldn't even turn around to look. They had to, and I noticed. I looked up in the middle of the concert. I was like, they're not enjoying it. They can hear it, but they are literally looking forward. They're not even looking at a glass back, because they could be fired like that, right? No one in the water, because everybody's at the concert. It's on the beach. Everybody's in the concert area. Nobody is at that part of the beach and to the shoreline, except those guys. They're in their chairs and they're just staring. You can tell they're pissed off. They're just like. But that's what NICU. You're looking forward. You need coverage to go to the bathroom break. You need a coverage to get a cup of coffee. Literally, and that's where my girlfriend was like, I miss the babies. I miss bedside, quote unquote bedside, cribside, bassinet side, whatever you want to call it. But she doesn't miss the fact that she needs to get coverage to go to the bathroom and get a cup of coffee. She can just walk up. She's desk jockey now. She can just do that. So it's a totally different level of attentiveness and commitment. And that might not be conducive to Gen Z. Maybe to Gen X, maybe to the millennials, definitely to the older generations, because we were taught differently. We have a different work mentality. And I say this for all my videos, by the way. I speak in generalities. I speak in averages. I do not speak as a hard, fast black and white. I don't believe in black and white. I don't believe it's this way or the highway. I believe in shades of gray all across the spectrum, except for the very ends, But the world is shades of gray, much more than 50. So that's what I'm talking about. I'm not saying this is the only way in. This is the only thing. You should not go ICU. No, if you want to go ICU, go. My daughter, over and above my suggestions, my recommendations, she did it. So I'm not here to say, hey, this is the only way. My personal life says differently. So, But she does lament it. She regrets it. She said, if I had to do it over, I wouldn't have done this. And she answered her own questions, and that's how I taught them is she's like, but there was no way you were going to change my mind. Absolutely no way, Dad. I was like, I didn't try. I tried, and that was it. I gave up, right? I stopped. You're a grown person. You're a super adult now. You got to make your own decisions and own mistakes. She did stack the deck against her. So, and I said that to her. I said, you chose to do onboarding, orientation, ICU, also start your BSN, because she's got an ADN like me, and you had your relationship stuff and your young summer girl bullshit. Okay, hot girl summer, whatever. Wrong. You concentrate on your job and get that squared away. Everything else follows afterwards. Because it's not like, oh, you gotta concentrate on your career for 10 years. You gotta concentrate on your career for 6 months, hon. That's it. I'm just saying, 6 months. And this is the girl that was thinking of going to medical school, and I said, are you ready to give up your 20s? And she looked at me and said, what? I said, this is how much you got to go to school. This is your prereqs for med school. Then you got your internship. Then you got your residency. This is when you're going to be an MD kind of on your own, senior resident at the very least. And she was like, that's 32, 33, 34, whatever. And she's like, are you fucking serious? I was like, you seen some of the residents in your EMT career now, and you see them, you hear them, you've got some of them come, making passes at you, and what kind of schedules they have. Can you live that life? She was like, absolutely not. I'm not that devoted to the craft. I said, then there you go, there's your answer. You're not going to go med school, you're going to go nursing or something else, right? She's like, yeah. That was a quick question, right? That's the thing. That requires a lot of devotion to go to med school. Nursing, not so much. But that's also the thing is you have to commit to your career for at least a little point of time. Get on board and get yourself trained. Then you got everything else. Then let your hair down, and that's why nurses party hard. We party hard. Not so much me. I'm 54, and partying hard is zooming through Netflix. I get to the exciting part. Right? But that is the difficulty with going straight into ICU. It is a quick bolus. And this is a fallacy that almost most nursing students think that when they graduate, we're nurses. I did the same thing. And then you realize, even a lot of the ones that say, yeah, I know differently. I know I'll be learning on the job. When they get to the job, it is a totally different animal. And they're like, oh my God, I had no idea. I said the words, but I really know nothing, and I'm learning everything. Oh my God. You're learning how to be a nurse on the job. It's like I say to my kids, 5 kids driving, getting their driver's licenses. You've studied enough to get your driver's license. Now that you have your license, now you learn to drive. And they all 5 of them are like, I know how to drive, Dad. No, they don't. And they didn't. And not really until they got to their first accident, really. And 4 out of 5, it wasn't their fault. It was someone else's. And I said, that's what I was trying to tell you guys. It doesn't matter how good a driver you are. It matters how good of a driver everybody else is. And they're like, I can't control that. I said, yeah, welcome to the world. Welcome to Earth. This is what we do here. This is humanity. Kind of sucks. Nursing, you learn on the unit. You learn your craft there, and it depends on the preceptors you have. ICU is just a tier above most of the other specialties. And I was thinking about this in a previous take. Was ED is probably the hardest. Emergency room nursing is probably the hardest because ICU, you've got 1 or 2 patients, they're intubated, sedated. That's what you're focusing on, and you can handle that. There's issues of time management and so on and so forth. I've mentioned that in other videos that everybody has to learn as a nurse, whether you're ER nurse, you're OR nurse, med surg, ICU, whatever, peds, you got to learn that. That's your first skill that you have to learn. It's kind of easier with 1 or 2 patients, even though it's so much objective data that you've got to process. You got to be a computer and really crunch that through. But emergency room, that's a whole nother animal. You can have 8 to 10 patients, and you don't know what's walking through that door. They could be like, oh, I've got a boo-boo on my finger. Oh, I'm missing a finger. Oh, it's a flesh wound. Oh, it's a flesh wound. Oh, I got something sticking out of my head. Oh, I got something sticking out of my ass. You don't know what you're going to get. You have absolutely no freaking clue what's walking in and what you're going to get assigned. It would be actually better for you if you got 10 patients, the same things sticking out of their heads, or 10 of them sticking things out of their ass. Because at least you're like, well, they're all the same. I don't have to, it's easy. You're like, what? It is easy because you don't have to change gears. You could have a kid, you could have an elderly senior citizen, you can have a middle age, you can have a young married couple, you can have a teen couple, you can have an abuse case, you can have a Karen, you can have it all, and on the same shift at the same time. So you can have a homeless guy, you can have a billionaire, it doesn't matter, you can have them all at the same time. And you gotta treat them. That's the difficulty of ED. And that's why I was like, ER nursing, I was like, nah. I floated a couple of times, I was like, this sucks, I don't like this. Because you've gotta really do it quickly. Whereas med-surg, I do have the same population, because guess where they go? If they're admitted and they go upstairs, I get them. I get them for 12 hours, but I get them for 12 hours rather than 12 minutes or an hour and a half or, whatever, or they're just coming in screaming. They're usually got some kind of meds on board and at least, have the object removed or plan to be removed, So I think emergency room nursing is probably the most difficult aspect going in. ICU coming second with its difficulty level. And that's the thing you've heard, hold on. One of the few edits of my many videos, my daughter, you might have heard that little blurb. That's why ICU nursing is what I say very difficult because of all the raw data you're crunching through, and how my daughter's being trained is a snippet of it. In the sense of like how she's being trained. Is it appropriate? Is it not appropriate? I do have objections to it. I have critiques of it, but in the end, I'm a third party. I can, you can always find criticism in something, right? That's the thing. But there is significant and real hurdles that new nurses going into the field will face. This is across the board until maybe that cohort takes over in a few years. And that's what I mean by that is most of the ICU nurses and preceptors therein have been trained the traditional way. And here comes this new batch, this Gen Z coming in, or even new grad older nurses coming in straight out of the box. There's some resentment there. I've talked to ICU nurses and that is there. And they'll still train you, they'll train you well, but there's that resentment. And is it harder? Are they harder on you? My daughter's mentioned that. She's like, all these guys have gone this way, and here I am. They've even made it. They made the comment right to my face. And I was like, that's some passive aggressive bullying stuff, on whatever. Now will be actually another video coming up. I'm going to do a bullying video. That was actually asked a while ago. I'm still working on it because I've done a couple, but I wanted to update it. But it's there. It's going to be there. There is resentment there because they say, we did our time in med-surg or step down progressive care, and here's this new grad nurse coming in knowing shit, and we've got to treat them as equals. We've got to train them. So there is some resentment there. Just be aware of that. You think you'll see it right when you get into it. You'll see it, and ICU nurses, if they're going to be honest, that's it. It's there. It's just, you paid your dues, and all of a sudden this young kid is coming in like that. That's the way it is. But also on top of that, and I'll give you the preceptor's point of view, my girlfriend's point of view, is she's like, I don't have time to teach the basics. We're in the ICU setting. Patient's gonna die. Baby's gonna die right in front of us. Don't have time. That alarm sounding is not a suggestion. You need to react And that's where she was at with some of the, and that's one of the reasons she left. She's like, I can't, I don't have the patience to train the basic nursing. You could do it, me, but I'm here to teach ICU level nursing, and they have to be diligent, they have to be responsive, they have to be responsible. And that's a lot of the critique, and some of that kind of shades back to the passive aggressive stuff, that the preceptors are passing judgment on this new crew, this new cohorts that are coming into the ICU. They're like, you need to know time management. You need, and it's funny. Not many people word that skill. I've noticed that, and again, this is where my channel, I think, excels or really has a niche, is that I talk about stuff other channels do not. We're not going to talk about the typical popular stuff or real skill stuff. You're not going to learn any skills here, by the way. No skills. I'm not qualified to teach any nursing skills. The only nursing things I'm qualified to teach you is bitching and moaning. That is an acquired skill. You'll learn that at the nursing station. I'm really good at that. And that's where I give to you guys. This is where I'm really good at. I'm going to point out stuff that you need to know. You need to know bitching and moaning, by the way, to fit in. But you need to know time management stuff. I can't tell you how to time management. You kind of learn that. Maybe your preceptors can teach you. You develop your own stuff. There's a lot of things, But that's where my channel is. We talk about stuff. I talk about stuff that really isn't discussed for whatever reason. And I'm like, that's odd. Handoff and time management and stuff like that. And the passive aggressive stuff of bullying is not addressed. I mean, yeah, they're talked about, but not really addressed. How do you do that then? How do you do this stuff? And maybe I'll do something on that and really start expanding on that, because it's a nursing skill, but it's not really a nursing skill. So, I mean, I'm pretty good at putting in Foley's in. I'm pretty good. I'm getting better at IVs. I'm pretty good at assessing it for certain things, but I'm not great. I'm not going to teach you any of that because I'm not good enough to. My skill set is somewhere else. And my girlfriend will say that, teaching these new nurses these basic skills is not what ICU setting is all about. It is not the place to learn. You are not going to learn how to fly when you're up in the air flying an airline. Yes, you're going to learn to fly in the air with an instructor. That's the precept, but it's not like that in ICU. You're flying in the air with an instructor with passengers. That's the difference. And that's why I say, be careful. Be very careful. If it was just instructor and student, flight student, that's different. But that's where the process gets muddied and very serious, in that you have a full plane load of passengers. You have this little baby in front of you. You have patients right in front of you. You're responsible for. You're not doing a dry run. This isn't clinical on a little CPR dummy. This dummy is living, and you got to be aware of that. So that's where I say ICU may not be the best way, whereas like med surg, the plane's still on the tarmac, they're going to go down the runway real fast. We're not taking off. We're going to turn around and keep doing this, looping around. That's what I did with my kids. I literally drove around our driveway for hours. They loved it. They were fine. And they're like, okay, I'm ready to hit the road. I said, no, you're not. We're going to turn left. We've been turning right. And they fuck up left. And I said, you think you're ready for the road? You can't turn left. You know rights really well. Now learn lefts. And they're like, oh my God. They had that major adjustment that, holy shit, I can only turn right. But I taught them all that same way. And it gives them a chance to step into driving. Same thing with med-surg is what I'm trying to say. I'm not bashing the commenter that critiqued my video. I appreciate that feedback. And, he called me, she called me a dinosaur. And it is right. But I think the dinosaur way of teaching and training nurses for ICU is still appropriate. Like you wouldn't, I think that person would agree with me. I think they're a seasoned nurse. You wouldn't, it's not good to drop a new grad into ER. Every time that I've seen, I've only seen a handful of times, they've all washed out of ER. They're like, nope, bye bitches, getting out of this. And either they quit nursing or they switched over to med surg. And that's usually where most people, like if wherever they wash out, where do they go? They go to med surg. So that tells me something, right? That should tell you something. Sorry it's such a long video. I had a little edit, hey, we're getting more advanced on this stuff. I'm learning, but hopefully this one will take. I've shot this like a half dozen times. Hopefully this will take. All right, good luck. Any questions, comments, please. I do appreciate them. I welcome them. And I do shoot videos. And that seems to be the best feedback that I get. That, people are interested because they ask the question and they watch it. So yeah, I don't mind. I just, I'm shooting hundreds of videos now. I have a backlog of literally hundreds. So most of them will not see the light of day. But I do address every question I get. Okay? Good luck.